Good morning, everybody. Welcome back to Clinical Anatomy and Urology 1, the 1 minute Caruso show on Friday morning at 9 o'clock. We thought we might have a special guest star, the special guest appearance this morning. Dr. LaBarge is on Zoom. So Dr. LaBarge did many of the sessions for this, covering the material for this exam. Dr. Caruso did some of the sessions. I had the fortunate experience of not having to do any of the interactive sessions. But we're here to answer any questions that you have. So, how many people watched the video of Dr. Rich's question and answer session? Helpful? Not helpful? Helpful? Thumbs up. He's got to go thumbs up. Thumbs up. Thumbs up. Yeah, good. I'll let her know. She historically had always done a quote review session, but this year we switched. We convinced her to switch to a question and answer session. So the things that she talked about were in response to questions that her students had submitted in advance, and so she prepared a PowerPoint. We prefer to take our questions live so that we make fools of ourselves right then and there. So what questions have you got? And you'll have to excuse me, I have the wrong glasses on, and these are my computer glasses, so you're all out of focus. But if I close one eye, you're all in focus. My left eye has a posterior capsule cataract, and the interesting thing about that posterior capsule cataract is it has changed the focal length of that lens so that everything's in focus with my left eye. Everything's out of focus. You're all fuzzy. Everything's in focus. So there was a question back here. There was a question back there. No.
Okay, so this one I got. So there's been a little confusion on hip dislocation. The one that I gave you in quickly was an abnormality, just to get you used to. The most common one is a posterior, right? Damage from pain to pain. And that posterior means that the wall head sits posteriorly, right? But those muscles are always contracted. That's what shortens the hip and they can come up, right? So your glute is still working because they're still on the glute veracity. Your quadriceps are still rectus femoris, your radial psoas, they're still working. They're going to pull the ball and head up, but it's behind the acetabular. So now what do you have to worry about? What nerves are in the posterior aspect, right? Sciatic nerve, fontanelle, right? Superior gluteus, inferior gluteus. So you look toward those type of things. The one on the anterior aspect, very right? Because the anterior aspect has these strong ligaments. They're wide more. The one case that people are seeing is what I call the bungee cord injury, right? It's when you go down and dislocate anterior, inferior. It does cause a stretch to the femoral artery and down from all come on this side. There's a little more play, okay? But when it goes anterior to superior, there is a chance you can catch your femoral artery right around that pelvic rim and the two come together. In your case, we want to look at the mechanism of the injury. So we're looking at you know the posterior dislocation, you got no everything posterior. We know if it's a bungee cord injury, we know it's going to be a dislocation and most likely. The problem with the anterior inferior is your muscles are usually going to pull it up. That makes sense? So yeah, it goes anterior inferior by mechanism, but your muscles are going to pull it straight up anyway, so it ends up anterior and superior because all your muscles pull it up. Does that make more sense?
So how come like with the anterior dislocation the leg isn't true, it's not posterior?
It does. It's only anterior inferior for just a moment. That's what they don't realize in clinical practice. When you see an anterior inferior, once that femur gets popped, all those muscles contract and pull it up inferiorly anyway. They don't tell you that because they think it just stays there. It never just stays there. It takes us time. We have to sedate a patient, and then it takes like a whole ER treatment to kind of pull that joint back down. And normally I'm not talking.
So the one thing you need to take into account with the dislocation is the ligaments that keep the head of the femur in the acetabulum, don't go straight across to the femur. They actually go at an angle. And so because of the twist around the neck of the femur and head of the femur, when the hip is flexed, those ligaments are at their most relaxed state. That's why it's possible to dislocate it posteriorly when the hip is flexed. When the hip isn't flexed, there's a slight gap between the ligaments on the inferior aspect. And so when the hip isn't flexed, it's possible to dislocate the hip inferiorly. Yeah.
So when you look at it, you'll feel that recoil from the ligaments.
The farther you extend, the tighter those ligaments get, because of the direction that they wrap around the head and neck of the femur.
So you ever want to feel that with the ligaments. Right now, go to kick a soccer ball, you'll go 20 degrees to feel extension to 30 degrees. You'll feel, because it acts like a towel, you get a rotation up and you'll just want to spring back.
I don't know about you, but when I kick a soccer ball, I'm not paying attention to what my hip feels like. I meant for that ball.
Well, I know it's like
Yeah.
my wife gets me. Okay, I see the spring and the joy in her face, so it's like, okay. Not true.
Different question, could you depict the differences between the plantar fascia and then the plantar epidermosis, or is that like interchangeable?
They're basically the same.
Okay,
Yeah. The question was the plantar fascia and the plantar epidermosis. They're basically the same thing.
Going back to the femoral dislocations, I have two questions. One, which is more common?
So the more common one is the posterior dislocation, because when you knee is there's that gap, you're not wrong. That's usually a board question. That's an 8 or obvious. Well, dashboard.
Yeah.
That's where we get that. And that is the most.
And then second question, is it a fair like rule of thumb to say if there's a posterior dislocation, it's more likely to go back into the side nerve bundle and it's anterior, it's the artery?
The fair assumption to say when you look at our posterior, you look at the wall head sliding back and you look at our posterior, that's what it's.
Anybody who starts off by saying, I have just one question or just two questions reminds me, on social media, it's not unusual for people to say, I have just one quick question. How old are you and where do you live? I'm sorry, which one of those was the quick question?
Next, one topic that was brought up to me just a week ago is the lumbar plexus. Right? No.
Ooh, it's muted.
Lumbar plexus. Now, you care about the lumbar plexus, right? But what do we need to know? If you can draw it out, you're golden. You're golden if you draw it, right?
Remember the brachial plexus where you had C5 and C6 coming together to form the upper trunk? And C8 and T1 coming together to form the lower trunk, and then all three trunks had anterior and posterior divisions. And then you had divisions coming together and things splitting and drive me nuts. So the lumbar and sacral plexus are much simpler. Ventral rami have anterior and posterior divisions. So for L2, L3, and L4, for L2, L3, and L4, for the lumbar plexus, all of the anterior divisions come together. They all come together as the obturator nerve. All the posterior divisions come together as the femoral nerve. And so right off the bat, trunks, cords, that's brachial plexus. So lumbosacral plexus, we're just going to have anterior and posterior divisions. And for now L4 and L5, L4 has a split that joins with L5, and we will name that the lumbosacral trunk. We'll see that when we do pelvis. That lumbosacral trunk crosses the pelvic rim and joins with and contributes to the sacral plexus. But even that lumbosacral trunk and S1, S2, S3, anterior and posterior divisions. All the anterior divisions come together as the tibial nerve. All the posterior divisions come together as the common fibular nerve. So the lumbosacral plexus is much simpler to draw. Nonetheless, you'll see it in pelvis, but recognize that it's contributing to these named nerves, and it's useful to know which ventral rami are contributing to which named nerves. And then everybody wants to memorize, it's this spinal nerve that's the major contributor to innervating this muscle. So, but the reality is that you don't necessarily need to memorize that if you recognize that there's a very interesting pattern there because of the way the limb developed. When you look at the somite that had a relationship with L2, it didn't migrate out the limb very far. And so muscles that are really close to the most proximal muscles that associated with the lower limb are going to be from L2 and L3 somites, which means that L2 and L3 spinal nerves, either anterior or posterior division, will innervate them. The somite that migrated all the way into the foot is S2 and S3. And so all of those intrinsic muscles of the foot, the medial and lateral plantar nerve and deep fibular nerve that does the two muscles on the dorsal surface, that's S2 and S3. And so you don't necessarily have to memorize which of these spinal nerves that contribute to this named nerve are the major innervators for this specific muscle. If you know that proximal to distal pattern of migration for those somites into the limb, dragging the spinal nerve innervation with them. So that pattern existed in the upper limb. C5 and C6 move the shoulder. C6 and C7 move the elbow. C7 and C8 move the wrist. C8 and T1 intrinsic muscles of the hand. That's why upper trunk injuries gave you motor deficits at the shoulder, and lower trunk injuries gave you motor deficits in the hand. Sensory is different because of the dermatomes, but we're talking motor deficits for innervation of the muscles. That same pattern exists for the lumbosacral plexus. So, yeah.
It's like a related question, so, are you training people for your you said that your was all
So the that deep fibular does the two muscles on the dorsum of the foot. So that makes the deep fibular the equivalent of the radial nerve. So although the radial nerve has no motor innervation on the back of the hand, if there were muscles on the back of the hand, they'd be radial nerve. That tibial nerve is the equivalent of the median nerve and the ulnar nerve combined. So when you get into the foot, everything, plantar surface of the foot, all the interosseous muscles, all those, the muscles that move the big toe, muscles that move the little toe, all of those muscles are innervated by tibial nerve. Now, medial or lateral plantar. When you look at the medial plantar nerve, it begins with an M, and so does median nerve. So all of the muscles in the hand that are innervated by the median nerve, those same muscles in the foot that are associated with the big toe are innervated by the medial plantar nerve. So, opponent's hallucis. How many people can oppose their big toe? We have an opponent's hallucis, and it's innervated by the medial plantar nerve. The adductor pollicis was the equivalent of an interosseous muscle in the hand, so that made it innervated by the ulnar nerve. The lateral plantar nerve is the equivalent of the ulnar nerve. So that adductor hallucis, that deep muscle in the foot, that's innervated by the lateral plantar nerve. And all of the interosseous muscles are innervated by that lateral plantar nerve. Where the comparison shifts a little bit, the median nerve did the first two lumbricals and the ulnar nerve did the third and fourth lumbrical. In the foot, the medial plantar nerve does the first lumbrical and the lateral plantar nerve does the second, third, and fourth. That's the only real difference for motor innervation in the foot when you compare it to the motor innervation in the hand. So if you remember the hand, oh wait, that was so last exam, I don't even know that anymore. So, but when you get into clinics and you see these problems in the hand, the same problems can exist in the foot. So how would you injure the medial plantar nerve? How would you injure the lateral plantar nerve? You gotta step on something.
It's vital.
Yeah. Let go. So we got this, I still have this giant ton of Lego from when the kids are little, all my kids are, you know, my daughter is 28, but both sons are 30 or old, 30 and 32. And, but my oldest son in the Navy, he still plays with Lego. Well, these really cool Lego kits. He gave me a Lego bonsai tree for Christmas. He gave my wife a Lego dragon. So
So we can look at injuries, right? And we can look at where you stepped out. So that's a good one they always use. Construction workers stepped on the breast, on the medial pass shot this. Fashion.
step on a shard of glass.
He's having problems where with life, but also in intrinsic muscles that medial and and so those are some of the questions you'll have. And you'll say, oh, on the land, the lateral aspect of your arch. You might have what last. That would be.
Yeah, when I look at the stem of the question and I see stepped on a nail or, you know, stepped on a shard of glass or the nail gun like that, you're probably gonna see something about the medial lateral plantar nerves, because that's how they get injured. Otherwise, it's tibial nerve. Yeah.
So now, stimular nerve, we'll get where your stimular nerve is gonna be at certain places, right? On back of the leg, right? Process, higher nerve bundle. So we're gonna work your way up and down the chain. So where you're doing problems, say, okay, here's a list of numbers, here's your location. You got cut here this way, you got cut here this, you got cut here this. And conversely, you got here, what still works, what doesn't. Yeah, one more question because we only have one question.
Which one of these is the quick one?
So this,
Okay,
So we don't ask what's the most common.
because that's not, what's gonna happen in clinic, you're gonna see, you're like, this is the most common. Well,
We tell you that this is broken or show you an X-ray.
Yeah. We'll say, we won't give you this is the most common factor, because then you're not using the brain, that's not how it's factor. And the reality is the most common factor is what the fifth metatarsal base, when you roll your.
Yeah, that's Dr. Lamar's.
Yeah, you roll your ankle and you sprain because that what? Your first ligament, right, it pulls off your bone, and that's kind of. Right, the ones that are more common after that are malleolus fractures, right, in that order because they're severity. Halo fractures are really hard to get. I've only seen two in my lifetime, and they have other fractures and other problems going on.
So what's the most common injury to the fifth? Let me phrase that differently, because I'm not gonna ask which is the most common injury. What's the most likely structure injured with a fracture through the proximal shaft of the fibula, just distal to that proximal head? Who's there? Common fibular nerve. You remember the older nerve, the elbow, medial epicondyle? The common fibular nerve is superficial, just distal to the proximal head of the fibula. You can palpate it, and if you feel it and compress it, you'll get a tingling sensation in your foot. So this is why if you sit with your legs crossed, with one leg crossed over the other for a prolonged period of time, your foot will start to fall asleep. You're compressing that common fibular nerve.
Now, what does your common fibular nerve do, right? It gives rise to your deep fibular and much superficial. So are you gonna get foot drop? Are you also gonna have inversion problems? Yeah, so that's how you separate the common fibular, right? Now, are you
Do
gonna
you have inversion problems or eversion problems? Eversion, why? They do fibularis longus and brevis in the lateral compartment, they're both eversion.
that's how you're gonna separate questions. Oh, patient was stabbed or bit by a pit bull on the lateral aspect by the annular head. Now you're like, okay, what they're, common fibular, you have both sides using the problem. There needs to be superficial Didn't have it sometimes, we've already talked about that. Foot drop is usually associated with the vestibular and that anterior compartment having. And that's how you work your way through problems. You work that way systematically, take your time. Don't just dive to the detail. Okay, where are we? What location are we at? What is the function? And a lot of times I see guys go for details right away. And you're like, ah, fibulary butterfly. Okay, go back, tell me what you're doing.
There's a question in the chat. What's the gold standard for dermatomes in the lower limb? The one in the book, in your textbook. The one in your textbook should agree with the one in Netter's Atlas, but interestingly, this shows you both the autonomous zones and the dermatomes. So notice those dermatomes spiral around that lower limb. So that's because that limb rotates. There's a difference between the dermatomes and an autonomous zone is a region of skin that's innervated by a named nerve. Dermatomes are regions of skin innervated by a spinal nerve. So when you look at the medial epicondyle, that medial epicondyle has a dermatome of S2, actually L4 on that medial epicondyle. Why would it be L4? We know it's saphenous nerve. And saphenous nerve is a continuation of the femoral nerve, which comes from L2, L3, and L4. And so the farther down you go, the farther down those numbers. So for L4, even on the sensory side, you're going to get all the way out to the medial malleolus. So L4, saphenous nerve, medial side of medial malleolus, medial side of the foot. L5 and the deep fibular nerve, skin between the first two toes. So
A good way to do your dermatome is turn your foot out. And
unspiral the dermatome.
L4 goes right over the medial side of the kneecap, right all the way down. So you're gonna do L2, L3, L4, L5, that's one, that's two. So you don't have to memorize together. So no, L4 goes over the knee from the lateral to the medial aspect. All right, it's closer, L3, it's closer to L2. It's further, it's L5. So you can memorize each individual one, or you can have the general pattern.
They want to know which is the gold standard, A, B, C, or D. First of all, the D and D are both posterior views, and A and C are both anterior views. And so what you're seeing is the variation. We will typically use C and D.
How could that be done without reflexes?
So reflexes, the major testing areas of the lower limb, right? You can do reflexes. But that's what, when you're doing L4, L5, right? But mostly we do sensory or motor. You don't do mixed in testing, right? Because that's motor and sensory in two different ways. Sensory tends to be what? Sensory in itself. And so we tested the dermatomal pattern. Motor tends to be multi-level because most motor actions have more than one. That's for individual movements versus spinal tap. When we think of dermatomes, we think of testing spinal levels. When we think of motor functions, we think of multiple levels or spinal together.
If you have a compression of a nerve, can you get motor deficits without sensory deficits? No. Can you get sensory deficits without motor deficits? Yes. Which is why you test them separately. So the sensory axons are more susceptible to compression injury than the motor axons are in any peripheral nerve. So if you start to compress the ulnar nerve, you get a tingling sensation on the medial side of your hand, but you don't have any motor deficits. When your hand falls asleep, do you have any motor deficits? When my foot falls asleep, I go, maybe I shouldn't get out of bed. But I get out of bed and I can walk just fine. but my foot's still asleep. Because those sensory axons have responded to the compression first. But you have to have prolonged compression or dramatic compression to affect both the sensory and the motor.
So practitioners in the future, anytime someone comes in with numbness or pain, right, you test the motor to make sure it didn't get severe. You like numbness and pain. What we don't like is, I feel nothing and now I'm having this. That's where we have to go. Outside is being sensory, inside is being.
But there's gotta be more questions. Yeah,
There was one question during class where we did a rupture of the Achilles tendon, and I just want to confirm that when you rupture your Achilles tendon,
it hurts.
are you completely losing tendon function?
No.
Or you're not, right?
Why do you, she wants,
Gets that question?
she wants to know why when you rupture your Achilles tendon. And interestingly, Achilles tendon is one of the very few eponyms that anatomists are comfortable with. So we've actually retained that eponym because Achilles wasn't a real person. And he didn't name it after himself. So it doesn't fit the complete definition of an eponym, that would be an anatomist having named a structure after himself. And yes, they were all men who named structures after themselves. Achilles was a demigod. So why, when you rupture the Achilles tendon, do you not completely lose plantar flexion? You have everybody who goes behind the medial malleolus. They are plantar flexors. They still work. And you have the two tendons that go behind the lateral malleolus. They're plantar flexors, even though they're also everters, they're plantar flexors, and they still work.
Now, so you want to see the greatest video on earth of an Achilles rupture, but the person that has, I gotta give you that thing, he is just straight gangster. He's Kobe Bryant, tears his Achilles tendon, walks, takes 2 free throws, just like straight gangster, no reaction, walks off the court. Like that is some OG stuff right there, right? Okay, but because the rest of it's over, but you'll see plan times calculus, so he doesn't have to do much better much. So he's dorsiflex with his, and he walks off. Right? I think there's another basketball player like 2 weeks later that it happened to. He's on the ground crying, he got heels off, don't Kobe to say chocolate. But when you have that Achilles rupture, it is so painful that many people cannot walk off. It doesn't mean in the ER, they'll test them for the motion, they'll find weakness, but not total plantar flexion.
And this is with soccer or European football. They would have fallen on the ground screaming before the tendon even ruptured.
Yeah. No, they're not even erupting, they just fall. They do the LeBron. Alright. Next question.
Yes.
Is there a difference between a superior flexor retinaculum and extensor retinaculum? Like, it looks like the same thing on C space.
The flexor retinaculum and an extensor retinaculum. So they would be continuous with each other, going
Yeah.
all the way around the ankle.
What about superior fibular retinaculum?
So I really want to say yes. Because this was a yes or no question. This is a question that can be answered with either a yes or a no, and I don't actually have to explain why it's yes or no. Just think about the flexor retinaculum and the extensor retinaculum, and of those, we typically think more about the flexor retinaculum. The extensor retinaculum, the one on the front.
Can you repeat the question, please? I couldn't hear it.
So
That
there
come
was
on.
about, is there a difference between the flexor retinaculum and the extensor retinaculum and the superior fibular retinaculum at the ankle? So, and a part of me wants to just say yes and leave it at that. So, but we typically only talk about the extensor retinaculum and the flexor retinaculum. That flexor retinaculum will be posterior and it helps to hold that Achilles tendon in place. And so before you rupture the Achilles tendon, you probably tore that retinaculum. But we typically deal with that extensor retinaculum, the one on the front, because that's injured more frequently. It's strained more frequently, but not necessarily torn. Yeah. And when it gets strained and there's swelling, it's going to compress that anterior tibial artery as it's trying desperately to change its name to dorsalis pedis.
From the ankle. From the ankle.
Below the ankle,
Below the ankle, we're gonna call it dorsal pedis, right, above the ankle.
dorsalis pedis is my favorite artery. Not because we ask about it, we do, so, but because I just like the term dorsalis pedis. It has this ring to it. I always wanted to get a great mastiff. These were guard dogs bred in Europe. They look like lions, and they're the same size as a male lion. They have a big mane around their head. They were bred to guard the castles. I want to get a great mastiff and name them dorsalis pedis. So that I could go out on the back porch and yell, dorsalis pedis, and see this lumbering huge dog come out of the wood. So that's just me.
I wanna get it in close, like I want it in the humor. So when he comes out, he comes out. It's like this huge dorsalis, so yeah.
Is it okay if you go over the how to locate the injection site for needles?
Okay, so gluteal injection site, right? We want the superior lateral aspect. So when we're doing palpations, one, please tell your patient you're palpating them before you inject them.
And before you put your hand on their butt,
Put your
tell
hand
them what
out.
you're gonna do.
You're gonna say, hey, I'm locating a safe area to give an injection. Normally we use our PSIS, right? Because that's the one that's most posterior and comes out of the lung. And I use the greater trochanter. Right? Because I use the greater trochanter and I use my PSIS. I usually put up my first finger and I'm in the superior lateral left. Usually the easiest way.
And then let's say you do that incorrectly, what structures are at risk?
Depends on what font you're in. Okay, so let's look. If we're doing this incorrectly. Not practice lawyer, that he is, looking now. So if we do it what? If we do it superior and medial, right? We're looking at what? Superior gluteal artery and nerve, because that's where it kind of comes out, superior to superior fundus.
So if you hit those, what symptom will the patient display? Positive Trendelenburg sign and a Trendelenburg gait.
Alright, now the next one, if you go directly out, inferior and medial, right, you're hitting the what? The head of nerve, and your malpractice, okay, so you're done. It's just gonna be gone, okay? If you go inferior and lateral, right, you have a chance to hit cutaneous to the posterior thigh, very well. More importantly, you end up hitting bone, because your greater trochanter there, give an injection like that. Sometimes you give the patient bursitis and a big lawsuit, because you literally want into the first time. Right, that's a.
So remember that COVID pandemic, that fake news, the COVID pandemic from a few years ago, where we all got shots, and then we had to have a boost, we had to have a second shot to make it the most effective. So I got the first shot in my left shoulder. Now, my left shoulder for the next 2 weeks was a genetically modified organism. It was a GMO shoulder. Because I got that seriously, they injected mRNA. Now, the other vaccine was DNA. And so when you inject DNA, you really are a GMO. So, but the mRNA gets degraded by those mRNases. And it takes about 2 weeks. So I only had a GMO shoulder for about 2 weeks. So I go in to get the second shot. And the nurse says, so where are we doing this? And I went like this. The visual at home and on Zoom, you can't see me pointing at my butt. So, right? And she said, no, we don't do that. So when he asks, I said, so do it in my right shoulder, because I had the first one in my left shoulder and I want to be even. So when he asked, how do you tell which, where to do an injection? I wanted to go like this on Dr. Druzzo's shoulder.
Yeah.
So
That's the way we do it on shoulder. Do it that way as well. Say what they want and what. So you want to avoid the posterior aspect of the deltoid, because that's where you're actually there, anterior, posterior, circumflexion. You say not that.
how many people could feel a reaction to that second shot? You didn't pay that much attention, did you? I could feel a reaction because, I started making antibodies that had already been there. I could feel something different that I typically don't feel after I get an injection. I couldn't feel anything in my butt.
Next question.
Wait.
Are any of the specific lateral rotators of the hip synonymous with specific muscles in the upper limb, or are they kind of just grouped together as synonymous with the rotator?
They're close, right? When we're looking at external rotators, right? The equivalent to roughly be. The Jamala would be kind of concurrent with your Harry minor, right? But they don't, because the way the scaffold goes. You're really the biggest one you want to know from the clinical aspect is piriformis syndrome. That you can have sciatic syndrome on your piriformis as a sciatic. Sometimes some patients have either piriformis, or you can scar up the piriformis and imbricate on the side.
She's asking this because there's an objective on the targeted objective sheet that says compare the muscles in the gluteal region to the muscles around the scapula. So, and now, what's the description of the targeted objective sheet? I don't know if you remember what I wrote in that announcement. These are the objectives that we will choose from. So when writing questions for the exam. That means that we're not going to ask about all of them. So, okay. That being said, if you take the lower limb and rather than orient it straight down, orient it straight out, abduct it fully. Now those muscles at the hip are in the same orientation as the muscles on the scapula. And that makes that comparison much easier. So, right.
With regards to the piriformis syndrome, is it always going to be sciatic, or will there be cases where it's common fibular? Because I think I remember it.
Well, when we comment into the right, because we're starting up too high.
So it would never split that high.
Actually, there are examples in the book where the sciatic nerve splits and a portion of it goes through the piriformis.
Yeah.
A portion of it goes through, and there's actually an illustration where the other portion actually goes above, instead of below. And so it just depends on what the symptoms are, which part of the sciatic would have actually gone through the piriformis.
So clinically, you treat it exactly the same, but here's how you know it, right? You're most likely to get a fibular head if the fibular branch goes through the piriformis, you get fibular symptoms. Here's the trigger. You're going to be palpating that piriformis versus palpating the common fibulars down there. That's the trigger. So if you sit on a wallet or do some long distance driving, and then you find some numbness in your lateral compartment, right? Or your anterior compartment, your fibular, but there's no problem with that. If you're like, it's palpated fine, then you're gonna look up and go, okay, this is most likely what there's forming symptom. And so you have to work your way backward and say, where is the insult? The insult is at the piriformis, then we're looking at piriformis syndrome, and you can delineate which branches you're from. Okay.
It's the most common way to injure the sciatic nerve. Put your wallet in your back pocket. My first pickup truck was a 4-wheel drive Nissan. The year after they switched from the Datsun to Nissan. So, and it had a bench seat. I could not drive that truck with my wallet in my back pocket. I got sciatic. I put my wallet on the dashboard so that I wouldn't forget it and leave it in the truck. So yeah. 40 to 45-year-old man who is not athletically active anymore, but was in his 20s and 30s, who now thinks he can do it again. And it really hurts. It really hurts on plantar flexion, because every time you want to use soleus or gastroc, it's triceps sura, gastroc, soleus, and plantaris. So anytime soleus and gastroc are going to contract, plantaris is going to contract. So anytime you have plantar, and because that tendon is torn and it's gonna get pulled proximally and it's gonna ball up, and eventually it'll stop hurting.
And I'll tell you the two sports you normally see the plantaris coming down. That's the ball. And
Number 3 is softball.
yeah,
That was my
always,
That was
yeah.
my father.
And this happened to my friend Dave Ruffin. He's a walk of fame. I went to tell that. It's like. So the plantaris,
If you tear the plantaris tendon, the only thing you will notice is it hurts.
so the plantaris, the primary action of the plantaris muscle is not the plantar function. It does some plantar function. But the reality is it's a posterior subject muscle. So your orientation is roughly. But every time you use the ankle, it's gonna hurt. It's gonna remind you that you're old. Okay, so there you go. Oh, yeah. It just hurts. It just hurts a lot. It just hurts not only in the leg, but your shoulder, because you're older.
So,
Hold on, so it's not the same as like stepping on a nail or something?
no, that's temporary pain.
Tearing your plantaris, they don't even go repair it. They don't put it back.
Just manage the pain.
Just manage
Tell me
it.
to take Tylenol.
Yeah, and then if you.
And that's not a reference to what's going on
No.
in this.
No, literally, they'll say, I've had it going on, right? Here's the ones that you don't want to give your patient. If they ever have an ankle injury or lower limb injury, don't give them an opiate, because, wow, they already have bad balance. Giving them something that's in more bad balance, not a great recipe for success.
And by the way, what the common recommendation for pain management until this whole Tylenol thing blew up was half the recommended dose of Tylenol simultaneously with half the recommended dose of Motrin. But yeah, that's for pain management. That turns out to be the most effective combination for managing pain. Tylenol by itself or Motrin by itself, half Tylenol, half Motrin.
So we put them together like a synergistic effect, will work very good.
I like the leads, but that's just me. Okay. Yes, so stop there.
There you go. You have to know.
The question was, you have to know it, you have to know anything, do we have to know anything about tarsal tunnel syndrome? So the answer is yes.
You gotta know target. Then
Who goes to the tarsal tunnel?
what you did before. Right, I'm good. Very nervous.
He goes to the tarsal tunnel. Okay, so there was a question, somebody showed me a question, you have an injury just lateral to the talus, tarsal tunnel. Just lateral to the talus, that would be the most medial structure in the tarsal tunnel. So, right against the bone. You're just lateral to the talus. The structure, yes, that would be the most medial structure. Think about it. This is like saying, the back of the knee, the most anterior structure is the femoral artery, and the deepest structure is the femoral artery. Wait a minute.
So normally, when there was a question, but I wrote it from a different perspective, you'll say, okay, injury at the medial malleolus just posterior. Right? Then you'll say, oh, just posterior. Very, there you go. So there you go, or the most posterior, it's a. Let's see, the form, right, I'm the closer, house is longest, right, it's the H. Or there is an injury in the carpal tunnel, now they're squirting red blood. Now like, there you go. But it was squirting bright red blood, well, that's what, and how it works, it's. Real and no artery, so like that's where you go. Oh, you have an injury to your carpal tunnel, and now the foot is swollen. Now you know it's the vein. Oh, you got injury to carpal tunnel, no blood, no swelling, now you got none of this. So you don't need you can
Then you have
work
weakness of flexion of the digits.
your way.
When that needs to nerve.
There we go, so you just work your way, it's like.
You have weakness of flexion, why? Why not loss? Flexion digitorum longus is in the leg. Flexion digitorum brevis is in the foot. What about weakness or loss of flexion of the big toe? Same thing, it's weakness because flexor hallucis longus is innervated in the leg, and flexor hallucis brevis is innervated in the foot. What about abduction and adduction of the digits of your toes? So if you lost the tibial nerve at the ankle, you lose abduction and adduction of the digits in the foot. Because you affected both the medial and the lateral plantar nerve. So it's what you got that.
All right, you have a question way in the back, right?
Yeah, I was gonna ask you about the objectives for Arlington.
That is a list of targeted objectives.
Yes.
They were just those, that's the same list that was distributed on all three campuses. So they didn't get any different objectives than you did. So, and they were and the description of the targeted objectives, I wrote that description. These are the objectives that we will draw from when writing questions on the exam. That doesn't mean we write a question about every one of them. But the questions that we did write, we could have written all the questions about one objective and you would have met that original statement. And that statement was supposed to be transmitted to the students in Harlem and the students in Montana with that sheet.
So all the questions will come from that sheet, but we won't get every single objective.
Yes.
Right?
It's not a review sheet. It's an NARS, not a review sheet. And the reason it's not the review sheet, you knew there was going to be a question about every one of those because it was written looking at the questions. This is a targeted objective list, doesn't guarantee that there's a question about each one of them. And if you look at, I would urge you to look at those objectives and compare them to the objectives in the syllabus. And you will see that 90% of those objectives are word from word out of the syllabus. So why did you want a review sheet if all I did was give you the objectives from the syllabus? Yeah, because it's the review sheet is purely psychological. It makes you think you're more prepared for the exam than you would be otherwise. That's all it does. But that increases your performance. Not by much. So, but seriously, you're not going to get a review sheet in neuro. Sorry, you're not. You're going to get a targeted objective list in neuro.
You know, we did a review sheet.
In life.
With patients.
I don't know, I'm gonna tattoo all the problems before I go in.
No, well, I'm saying, like, but if you hit your objectives, you're not learning a specific question. You're learning how to deal with the objective. So when you have multiple forms of the question, and totally relax for the key topic.
The students here, at least a small group of students, put together a document that's addressing what they think you need to know to meet all of those objectives on that targeted objective sheet. So I checked that document for correctness. So everything on that document is correct. I did not check it for completeness. There might be things missing. And there might, it's a guarantee, there's too much for some of those. So, and for some of them, just putting anything on there doesn't help you because we asked about that objective.
Alright. Yes.
Yes. Do you need to know the different tests? It's actually one of the objectives and how the ligaments at the knee and how they're tested. Is that
You know the specific test, right? You posterior door, anterior door, right? You have it right there. Anterior, ACL, one the anterior, right? Test the ACL, PCL, right? Obviously, it's very easy. Very, but if you learn it that way, you now know every single blow or trauma, and you're good to go.
the other thing you need to recognize, but not necessarily for the exam, you don't just test one side of the body. Always compare it to the other side, especially when you check testing the medial and lateral laterals.
And here's how we would do this one. We're checking the ACLs. I'll sit the patient down and I check the good leg first. This is the clinic. Check the good leg, I'll do the anterior and do the posterior door, I'll do the medial abdominis femoris stress test. I want a baseline. Then I go to the bad leg and I'll pull anterior. I go, oh, that ain't good. I don't say that to the patient, I internalize it. And then I'll push posterior, right? Because it's very rare to have a posterior, you can have it, I'll push posteriorly, so. Right, be very confident, even though I'm calling it a low right away. You got it, and I'll look, because now I'm like, okay, the anterior tibia slid forward, I need my ACL, it's gone. My medial collateral ligament, when I stretch from lateral to medial, that was there, okay, so that's intact. When I stretch from medial to lateral, that was gone. Now I know my LCL is gone. What I call ortho, I go, hey, ortho, broski, right, I know you don't know anything about physiology, but I got an ACL that's gone, I got an LCL that's gone. Livable. There we go, and we fill it, and we use some blacking down. But that's how we go work with it.
Obviously, we like you know how to identify them, but like what possible questions could come about, like would it be like,
What possible questions were happening here, right? Until you close and say, okay, I see an injury. And then someone like put an arrow said, there's a blockage here. What compartment, what motion?
Or like the example that Dr. Russo had in his interactive session question. You know, which, you know, of these labeled things, which one of them was vascular. Of these labeled things, which one is supplying blood to the region where that you're interested in, the stroke center?
They might say, oh, this artery goes to what? Well, we want to know that we're going to categorize we're looking for a blockage and the patient having difficulty with adduction, or the patient's having difficulty with knee extension, versus they're having difficulty with what? If abduction. Each of those arteries correspond to a component, so look at it in diagram by contrast.
More questions? More questions? So,
Yeah.
yes. No,
Can you go over shin splints?
Oh, shin splints.
never happened.
So what
I
are
was a
shin splints?
competitive runner for more than 15 years. A runner for more than 50 years. Never had shin splints. Ran 18 marathons. Never had shin splints. So I'm weird.
What are shin splints?
The technical term, anterior compartment syndrome. That should tell you everything you need to know. Anterior compartment syndrome, that should tell you everything you need to know. So,
But the reality is your periosteum gets inflamed if you're exercising so much. The fascia gets inflamed between your anterior compartment muscle, or you start pulling on the periosteum of bone.
so any inflammation in that anterior compartment, the fascia on the anterior aspect of that compartment is so dense that any swelling, any inflammation in the compartment causes pain and compresses the nerve and blood vessels in that compartment. So that's anterior compartment syndrome. So what do? So if it's persistent and chronic anterior compartment syndrome, you know those fishnet shopping bags that they have? You know, you've seen these fishnet shopping bags, the more you put in it, the more it expands. They make that anterior fascia into the equivalent of that fishnet.
Yeah.
They essentially make a series of holes that's very small slits that are out of alignment with each other. You know, in the part, when you go medial to lateral, and that allows the fascia to expand laterally, but still maintain the integrity of the compartment.
Better way to do it is ibuprofen, Tylenol, stop running for a little bit, or kind of stretching and getting good mobility.
I don't know any marathoners that can do that.
Stop running.
Yeah, they just won't. So. Yeah. Yes.
We also read somewhere that anterior compartment syndrome can also occur in tendon fractures.
Yes. Because the fascia is so tight, yeah, you can have that, and then you have to do a fasciotomy. Because remember, long bones have a lot of blood. Marrow, the twigs, so they have a lot of blood. So you get your blood from the tibia, you can get into your side. So that makes your compartment. Remember, long bones have a lot of blood, because very arteries for the femur, and all these contributing arteries that lead to the tibia. That's why you can do an interosseous IV to the tibial head. You don't have good IV exit to a right into the bone.
In theory, you could get anterior compartment syndrome with a fracture of the fibula,
Which you could.
because it's one of the boundaries of that compartment.
But not as much as that's it. It's both.
Doesn't matter. Is the thumb lateral or medial to the little finger? Is the thumb lateral or medial to the little finger? If I pronate the hand, is the thumb lateral or medial to the little finger? Right, so it makes no difference what the orientation or that line of reference that you see to the fingers of the hand.
Because your medial malleolus is gonna be what? Medial to the but it's just gonna be oriented.
And medial and lateral are used in the anatomical positions. And so you supinate the forearm, your thumb is lateral. Pronate the forearm, that's not the anatomical position, which is why the thumb is still lateral. Yeah, saw that. It's left. Yes.
Could you quickly clarify the divisions of the popliteal artery?
So the popliteal artery, that popliteal artery wants to branch into an anterior and a posterior tibial artery, right? And then one of those wants to give off a fibular artery to go to that lateral compartment. That is not a branch of the popliteal. The popliteal will split into anterior and posterior tibial. And then off of that, I think it's off of that anterior tibial, you see that fibular artery. That fibular artery, some of the books call it the deep fibular artery. Same thing. So,
You have to realize that interosseous membrane, that's that boundary, right? So the anterior versus posterior tibial. Since the posterior tibial artery is more muscle, it's generally gonna be bigger. The anterior runs in the front. Then you double check on angiograms, I'm sure people tell you is your posterior tibial artery has to travel around your medial malleolus. That's your double check. The anterior runs the anterior compartment, posterior goes with the cletus. Then you have the fibula going sideways to the tibial head. How we doing? Very good. All right.
No other questions? If there are no other questions, we will hold the morning window show to the end. Good luck on Monday. Thank you.
Recording stopped.
I don't know.